All right, let's dive right in. We're going to break down the three frontline medications for opioid use disorder, or what we call MOU. Now, these are really powerful tools, but they work in completely different ways. As an addiction specialist, my goal here is to just demystify them, how each one works, who it's for, and why they are absolutely the cornerstones of modern evidence-based treatment.
Okay, let's get this out of the way immediately. This is the biggest misconception out there, and it's the source of so much stigma. People ask me all the time, aren't you just substituting one drug for another? And you know what? The answer, based on everything we know about brain science, is a definitive no. And I'm going to show you exactly why. The key here is really understanding the difference between the state of addiction and the state of treatment. You see, active addiction is basically physiological chaos. We're talking intense cycles of euphoria followed by these awful crashes that just drive compulsive use, and, well, it makes it impossible for a person to function. Treatment with MOUD, it does the exact opposite. The whole goal is to create a steady, stable state by keeping the brain's opioid receptors occupied. This gets rid of the cravings, it stops the withdrawal, and it just normalizes brain function. It allows a person to finally start rebuilding their life. And this drawing, it just illustrates that point perfectly. Look at the top line. That's the physiological storm of illicit opioid use. It's just unpredictable highs and absolutely devastating lows. The entire goal of MAOD, which you see in that flat, stable line on the bottom, is to end that chaos. It is not about getting high, it is 100% about achieving a physiological stability that makes recovery possible.
Okay, so let's meet our first medication, buprenorphine. If there's one word I want you to associate with buprenorphine, it's safety. And that safety is built right into its pharmacology.
So buprenorphine is what we call a partial agonist, and this is so key. It binds to the exact same mu-opioid receptor that heroin and fentanyl bind to. But, and here's the trick, it only activates it partially. You can almost think of it like a key that fits perfectly in the lock, but it just doesn't turn it all the way. This partial activation is what creates that built-in ceiling effect.
And that ceiling is most important when it comes to breathing. See, with full opioids, the higher the dose, the more it suppresses your drive to breathe. That's what makes an overdose fatal. The buprenorphine ceiling effect means that beyond a certain dose, it simply doesn't cause any more respiratory depression. That safety feature makes it dramatically less risky than other opioids. It's a game changer. Now, there are a couple of other really clever features here. First, it has a very high affinity, which means it binds to that receptor like glue and can actually push other opioids off. Second, you'll often see it combined with naloxone in a product like Suboxone. So why do that? Well, the naloxone isn't absorbed when you take the pill as directed, but if someone were to try to dissolve and inject it, then naloxone suddenly becomes active and instantly throws them into a miserable withdrawal. It's a brilliant piece of pharmacology designed specifically to deter misuse. All right, let's move on to our second tool, methadone. Now, unlike buprenorphine, methadone is a full agonist, which gives it a different, and in some cases, a much more powerful role in treatment. So what does full agonist actually mean? Well, it means methadone fully activates the opioid receptor. There is no ceiling effect. The relationship is totally linear. A higher dose produces a stronger effect. And understanding this is absolutely key to understanding both its incredible benefits and its very real risks. And because there's no ceiling, the risks are just higher. They require careful monitoring. At higher doses, methadone can affect the heart's electrical rhythm, specifically something called the QT interval. So we have to monitor that with ECGs. And that no ceiling on respiratory depression, that means we have to be incredibly careful when we're titrating the dose, always following the rule of start low, go slow, to prevent an accidental overdose. So this really summarizes the trade-offs. The pros are huge. It has a very long half-life, so it provides stability for well over 24 hours. And because it's a full agonist, it's highly effective for patients with a very, very high tolerance, which, is increasingly common in the era of fentanyl. The cons, though, are that overdose risk and, in the US at least, the strict regulations that require patients to visit a licensed opioid treatment program every day, at least when they're starting out. Our third medication, naltrexone, operates on a completely different principle. It's not an agonist at all. Honestly, the best way to think of naltrexone is as a fortress, a protective wall. Naltrexone is a full antagonist. What that means is it binds to the mu-opioid receptor with a really high affinity, but it has zero activity. It doesn't turn the receptor on one bit. Instead, it just sits there occupying the receptor and physically blocking any other opioids from landing and having an effect.
This image of a brick wall is the perfect metaphor. With naltrexone on board, if a person relapses and uses an opioid like heroin, nothing happens. The opioid literally can't get to the receptor to produce that euphoria. This blockade completely removes the reward from using, which can, over time, help extinguish that learned behavior of drug use. But, and this is the critical catch with naltrexone, because it's a blocker, you absolutely cannot give it to someone who still has opioids in their system. The patient has to be fully detoxed, usually for about 7 to 10 days. If you give it too early, the naltrexone will just aggressively kick all the opioids off the receptors and trigger this sudden, severe, and frankly miserable condition called precipitated withdrawal. This brings us to a really crucial clinical pearl that applies all this pharmacology to what we actually do in the clinic. Let's talk about how to safely start someone on buprenorphine. Because, as we just saw with naltrexone, timing is everything. So this is the million-dollar question in the clinic, right? We know we want to start buprenorphine to help someone, but if we get the timing wrong, we can actually make them feel so much worse. So how do we know when is the moment right?
Here's the pharmacology behind the problem. Remember how we said buprenorphine has that super high affinity? It binds tighter than heroin or fentanyl, but it has lower intrinsic activity because it's only a partial agonist. So if you give it too early, while the person still has a full agonist in their system, the buprenorphine will just muscle its way onto the receptors, kick the full agonist off, and cause a net drop in the opioid effect. And the result? You guessed it. Precipitated withdrawal.
The solution is that we have to wait. We wait until the person is already in a state of mild to moderate withdrawal. And we don't just rely on what the patient says, we use a standardized tool called the Clinical Opiate Withdrawal Scale, or COWS, to look for objective physical signs. We're looking for things like dilated pupils, goosebumps on the skin, sweating, yawning, all these clear indicators that the full agonists are leaving the system. And here it is. Here is the magic number. Once a patient's COWS score is around 12 or higher, that tells us they are sufficiently in withdrawal. Their receptors are becoming vacant. At this point, it is safe to give that first dose of buprenorphine, and it's going to bring relief, not precipitated withdrawal.
So as we wrap up, the main message I want you to take away is that these medications are not interchangeable. Not at all. They are very specific tools, and the art of addiction medicine is all about picking the right tool for the right patient at the right time.
So let's just recap those crucial points one more time. Buprenorphine offers incredible safety because of that ceiling effect. Methadone provides powerful stability for those with high tolerance, but you have to monitor the risks. Naltrexone provides a complete blockade, a wall, but only for the patient who is already fully detoxed. And for induction, timing is absolutely everything, and it's guided by the COS score.
And let's come full circle. I really hope it's crystal clear now that using these medications is not trading one addiction for another. It's using precise pharmacology to counteract the neurobiology of a chronic disease. It is life-saving, evidence-based medicine. Full stop.
And really, that's the ultimate goal. The medication isn't the recovery itself, it's the stable platform that makes recovery possible. We stabilize the brain so that a person has a chance to rebuild their life. Thanks so much for watching.